Welcome back to the Doctor is in television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon right here in beautiful Monterey, California. Thank you so very much for joining us. I'm delighted you could be here today as I discuss one of my favorite topics of what I do all year long, and that's go on humanitarian mission trips to other countries, developing countries, and help children and babies and even some adults with unrepaired cleft lips and palates and burned hands and simple tumors and things like that. I'm delighted you could be here for this segment. I enjoy spreading the word about what Rotary does with Rotoplast, Alliance for Smiles, or with Plasticos. This past year, in the year 2018, I went on 3 humanitarian missions. I went to Cuba after the hurricanes. I went to Myanmar, and they still are having some difficulties with kind of a humanitarian crisis with the Rohingya, the Muslim or Islamic minority. And also I went to Guatemala following the volcano. There was a lot of work to be done. I think that's a pattern we see all over the world when there's a humanitarian crisis or a natural disaster. Probably much of the attention or much of the resources are taken away from social services or surgical attention for the children and babies with cleft lip and palate. And that attention and those resources are diverted away to help with the humanitarian crisis or to help with the natural disaster recovery. And certainly I think that's understood. But as I said, this year I went on 3 humanitarian missions, and I'd like to start by talking about our recent trip to Guatemala. We flew into Guatemala City, a relatively small team. I think this was only about 12 people. We had 2 surgeons, one from Philadelphia, myself, and we met up with a surgeon there in Guatemala City, a really good cleft surgeon, Milton Solis. This is a view from the hospital, and we see on day 1, what we do is we hold clinic. And during the clinic, we triage the kids and the babies. What that means is we actually sort them out and put them into groups. There are always children that we feel can be taken care of there, either by another team or by the local surgeons and nurses. And oftentimes we'll see children and babies that are in need of an intensive care unit or they're kind of sick. And so we usually discourage those babies and children. However, or discourage them from having an operation on that trip, and we'll usually try to get them to the United States if they need an intensive care unit or defer them to another clinic later that year. So the hospital there that we operated in, they were very hospitable people in Guatemala. We were delighted to be there, and they were delighted to have us. As I said, there was an earthquake earlier this year in Guatemala, and a lot of the attention that normally, and a lot of the services and energy normally directed toward the children and kids was diverted towards recovering from the volcano. And so we can see some of the volcanic range there outside of Guatemala City. So we fly into Guatemala from Houston. We set up in Guatemala City. They were kind enough to let us use this hospital to St. Lazarus. It's a public hospital there. And we triage the children and babies during the first clinic day. We typically see children with unrepaired cleft lips and palates. We see some burned hands. This is a little girl who has congenital ptosis. Ptosis is a descriptive term for the eyelids. Some children are born without satisfactory muscle to be able to lift up the eyelid. That's called ptosis. Sometimes people call that lazy eye. There can be a number of causes of ptosis. Of course, this can happen in the United States as well. Older people sometimes get lash ptosis, leading to visual field obstruction. A lash ptosis is when there's so much extra skin of the upper lid that the redundant skin rests upon the eyelashes, and it's difficult for the older adult to hold the eye open. Oftentimes there's visual field obstruction. The amount of light and the image that's coming into the eyelid is obstructed. That's called lashtosis. In older adults, too, the levator muscle that lifts up the eyelid can get weak or torn or have a neurologic problem, and so the activity of the upper lid is insufficient. That's called ptosis. So sometimes we operate on these children and babies with ptosis, or we can do a cleft lip repair. Here's a baby with an unrepaired cleft lip. We can see that that's a complete cleft of the left lip. What that means is that the cleft in the lip goes all the way up into the floor of the nose. That's called a complete cleft lip. And it can happen on the left side, it can happen on the right side, and sometimes it even happens on both sides. That's called a bilateral cleft lip. But for this boy, this young baby, as we can see, it's a complete cleft of the lip on the left. It just extends up into the nose. And of course, sometimes we see a cleft lip that's just barely malformed, just part way up the lip. That's called an incomplete cleft. And sometimes it goes all the way up. Now here's another baby with a complete cleft of the lip on the right side, as we see here with the mother. And this is a very common congenital anomaly, malformation that happens in the Hispanic population about 1 out of every 1,200 births. 1 out of every 400 births. The most common incidence of clefts is outside of Shanghai, China. 1 out of every 1,200 babies born outside of Shanghai, China has a cleft, either a cleft lip or cleft palate. In the Hispanic population, it's about 1 out of every 400 babies. In particular, on the western side of South America, in Chile and Argentina, it's about 1 out of every 400. In European countries, European nations, and in Canada and the United States, among Caucasians and Europeans, the incidence is about 1 out of every 1,200 births. The lowest incidence of any continent on Earth is in Africa. It's about 1 out of every 2,000 births in Africa. So some ethnicities and some groups have certain anomalies and certain diseases and certain predispositions towards illnesses or sicknesses that other countries don't, and it can be the other way around. For example, cystic fibrosis is very common in European and Caucasian populations. However, it's less common in the African population. However, sickle cell anemia is mostly confined to the African population and far less common in the European population. So again, I described the incidence of clefts outside of Shanghai, China being about 1 out of every 250 births, the western side of South America 1 out of 400 births, Europeans and Canadians and United States Caucasians about 1 out of every 1,200 births, and again in Africa about 1 out of every 2,000 births. So here's that child. As you can see, this is a complete unilateral cleft. It goes all the way up into the nose. And what's happening here is, of course, the teeth and the premaxilla is exposed. Those teeth and the alveolus are exposed to the air. They tend to get dried out, and it's not good for the health of the teeth. You can have a cleft palate along with a cleft lip, or you can have a cleft palate alone, or a cleft lip alone. The cleft palate, of course, is a split or division in the roof of the mouth. And there's the hard palate and the soft palate. It can be just the soft palate, or it can extend from the soft palate into the hard palate. Now, as we see here, the teeth lay upon or erupt from, they rest upon a ridge called the alveolar ridge. When the cleft extends through the alveolar ridge, then there's a split in the dental arch. So the teeth are misaligned, the palate can collapse, that arch of the teeth can collapse, and that's oftentimes why in the United States we'll have a cleft palate team, and there'll be an orthodontist as part of the team, an oral surgeon as part of the team, as well as a speech therapist, an ENT doctor, plastic surgeon, of course, some maternity nurses or pediatric nurses. It's a very complicated, complex, multifactorial issue, and multidisciplinary field, and the clinic is covered by different specialties, not just plastic surgeons. So there's the baby at about postoperative day number 2. you can see that that cleft had extended up into the floor of the nose, and that's the repair of the cleft lip, as you can see. The mom is very delighted. Something that I wanted to clarify, sometimes when audiences see these pictures, they'll think that during the surgery I missed the midline, or I somehow made a mistake or miscalculated, and the scar for the cleft lip ends up on the side or under the nostril instead of in the midline. Actually, that's intentional. The Cupid's bow is that part of the vermilion cutaneous border, the white roll that slopes gently up and then down and then up and then down. That's the Cupid's bow, in other words, mimicking for the bow and arrow, Cupid's bow, and the philtral columns extend up from the high points of the Cupid's bow, extend up into the nose. Studies indicate that when we lay the scar right on that philtral column, it tends to blend in very well. So we're not trying to put the scar or the incision right in the midline. We're trying to line up the scar right on that philtral column, emanating from the high point of that Cupid's bow into the nose. And that tends with time to fade quite well, and it actually mimics the philtral column itself. So a baby with a unilateral cleft lip, we want that scar to go up the philtral column, because typically a baby with a unilateral cleft lip will have the normal philtral column or normal ridge, and then the scar will be corresponding on the other philtral column or ridge, and then it tends to give the appearance of symmetry and harmony and balance. Now, when a baby has a bilateral cleft lip, then there's two scars. And again, we try to lay those scars and mimic the philtral columns, extending up from the Cupid's bow. Once again, if you think of the Cupid's bow like the bow and arrow, it's that bow. There's a gentle slope upward to a high point, and then slightly downward to a low point, and then upward again, and then a gentle sloping towards the corner of the mouth. That's the vermilion cutaneous border or white roll, and the Cupid's bow is right in the middle. And you know probably from fashion and beauty and models, a very pronounced Cupid's bow now is in vogue, and it's very attractive and very beautiful. There's something called a Paris lip that we try to mimic with injections of collagen and filler, and by plumping up the lip and accenting that vermilion cutaneous border. So going back to the baby or the child with ptosis, what we do is harvest some fascia. And the fascia is that collagen lining on top of a muscle. Sometimes in this country we'll use little silastic bands or little silastic tubing, an artificial substitute for fascia. But in this particular case, we go to the lateral thigh and we harvest some of that connective tissue. And what we do is we connect the eyelid, the tarsal plate, to the frontalis muscle in the forehead, because this baby, this child, even though she cannot elevate her eyelid very well, still her eyebrow can be lifted. That's because the frontalis muscle in the forehead is innervated by a different cranial nerve than the eyelid. And so what we're doing is creating a sort of rope and pulley system. We're using this fascia to connect the tarsal plate of the upper lid that's not being elevated very well because of the levator muscle, and we're tunneling it under the eyebrow and under the skin to the frontalis muscle that does work well. And so the child will quickly learn to lift her eyebrows and raise her forehead and then raise the eyelid itself. It's a type of kind of rope and pulley system. So that's a type of reconstruction and correction of congenital ptosis. Just very briefly, ptosis, when it has another cause, for example, too much excess skin of the upper lid, we can trim the skin, remove extra skin. When the levator muscle is loose or lax or torn, we can go in and shore up that muscle. Sometimes we repair it. It can even detach in some type of injuries, and sometimes what's called the aponeurosis, the levator aponeurosis, can get very attenuated and stretched out, and that can be a type or one cause of ptosis. And so we re-advance that levator muscle to the tarsal plate to restore the ability of a person to lift up and elevate their eyelids. So that's a relatively common operation done in children, especially in the United States. Cleft lip and palate we oftentimes will do here in the United States as well. So I'd like to teach a little bit and distinguish between a cleft lip and a cleft palate. As I said, the cleft lip is what you can see. That's on the outside. I think that's reasonably straightforward. Behind the lip, of course, is the ridge called the alveolar ridge, where the teeth erupt from. The roots of the teeth lay upon that alveolar ridge, and when there's a cleft of the palate, that's of course the roof of the mouth. That can involve the soft palate, that's the flutter valve that's way in the back of the throat, that the uvula, or the little tongue, the little fleshy part that sits in the back of the throat, and the soft palate. That serves as a kind of flutter valve, and what that does is help to redistribute the airflow in between the mouth and the nose. It's very important for certain phrases, such as cookie and Coca-Cola. There are these phrases or word sounds called fricatives and plosives, where the flutter valve is very important. The soft palate needs to go up and touch the back of the throat. That's called velopharyngeal competence. When there's a cleft of the soft palate, the baby will typically have a velopharyngeal incompetence, or VPI, and that in that type of instance, the speech can be poor because the baby cannot distribute the air flow properly in between the nose and the mouth, and so the speech is not always clear. So again, a cleft lip is what you can see. For example, here's a mama holding her baby with I think this is an incomplete cleft of the left lip. It extends almost to the floor of the nose, but not quite into it. So that's that's an incomplete cleft lip. So again, as I said, the palate can have a cleft as well as a lip, or they can be separate. Now here's a baby. I took this picture to demonstrate that the nose of a cleft lip child can be distorted. As that cleft continues into the maxilla, which is the upper jaw, and up into the nose, the floor or the nostrils rest on bones that are of different projecting heights, or the anterior vector is different, and hence the nostrils can be different, the alar rims can be different. So during that cleft lip repair, we'll oftentimes do a tip rhinoplasty and at least get started to straighten out that septum, straighten out the columella. That's the middle strut in between the nostrils, and at least get started to straightening out the deviated nose and try to bring some symmetry and reconstruct the nostril floor at the same time. So as we see here, here's a complete cleft of the left lip. And it's interesting for me when I look at these pictures, I'm reminded of some of the first modern cleft lip repairs. We can see that the Cupid's bow is there in the philtrum, but it's just that it's misplaced and it's kind of crooked. So the modern way to repair a cleft lip like this is to rotate that flap, rotate the philtrum down so it's balanced and has some symmetry and harmony, and then advance the lateral segment from the side where the cleft is and bring these two segments together. Also trying to straighten out the nose. Sometimes I am asked, why is it that these babies can get a cleft lip? Is there something in the water? Is there just something that goes wrong? Well, it's very interesting to me that on day 28 in utero, and keep in mind, that's before most women even know they're pregnant. So day 28 in utero, the facial segments are designed to fuse. The Meckel's cartilage that forms the jaw comes from the side to unite. The maxillary segment, or the upper jaw, they roll in from the right and left. And this is, again, at day 28. It's the sort of almost like a zygote. And then from the notochord, from the frontal nasal process, the central portion rolls down with the nose and the philtral column to unite with the lateral segments. And that has to be timed just almost perfectly. And if there's just something askew in the timing, if one segment arrives there earlier or one segment arrives late, then there can be a cleft lip as we see. So again, that's on day 28. Once it's in the congenital pool, once it's in the DNA pool in certain ethnicities, it's more likely to pop up. The cause is really multifactorial. If there's hypoxia for some reason or low oxygen tension across the placenta on day 28, a cleft can occur. Some certain medications such as phenytoin, dilantin, if that's on board, that can bring about a cleft lip. It's probably something related to folic acid deficiency or metabolism. Folic acid deficiency, of course, in this country can lead to spina bifida, spinal cord problems, etc. So it's pretty clear that families that have a tendency towards clefting, cleft lip and cleft palate, if the mother takes a folic acid supplement, probably the incidence of cleft can be diminished. But again, it happens on day 28, so a woman needs to start the folic acid supplements even before she's getting pregnant or very early on. There's the baby with the attentive mama. I think that's on about day 3 after the cleft lip repair. So what happens at the hospital? And there's that baby. As you can see, there's a sort of curvilinear or short incision under the nostril to help rotate in that left nostril, help reconstruct the nasal floor. We're reconstructing the philtral column and Cupid's bow. And there's a little incision under what we call the columella. That's the middle portion in between the nostrils. So what we're trying to do is restore some balance and symmetry and harmony with the cleft lip repair. And we're doing a little bit of a rhinoplasty as well, a cleft lip repair. Excuse me, a rhinoplasty. When we do the cleft lip repair, we're doing a little tip rhinoplasty. Sometimes I'm asked, in this country, why don't we see babies walking around with unrepaired cleft lips and palates? Well, that's because they get their surgery when it's needed at a young age. Now, in this country, with a cleft palate team, whether the plastic surgeon is in private practice or at a university or at an HMO or something like that, there's oftentimes other doctors around to help. As I said, orthodontist, an oral surgeon, an ENT, a dentist, nurses that can help teach feeding, because these babies with a cleft palate, they don't suckle very well. In addition to having problems with speech, they can't make that vacuum to suckle well, whether it's from the baby's breast or from a bottle. And so they're slow feeders and they can have low weight gaining. So in this country, a baby may get about 5 operations between the age of 3 months and say 16 years. We can do the lip, we can touch up the nose, we may do a bone graft to the alveolar ridge that holds the teeth, we can do the palate repair, we may do speech therapy, we may do a secondary rhinoplasty, and sometimes we even adjust the jaw and bring the jaw forward. That's called a Lafort procedure. So there's a baby on about day 1 or 2 after surgery. You can see where the incision lays right upon that left philtral column. We've restored the Cupid's bow. We've brought a lot of balance and harmony to the nose. And so I think that's, the baby's swollen here and a little bit discolored and probably is anxious to get into the shower or have a bath. But that is a typical appearance of a cleft lip and nose repair on about day 2. And there's the happy, grateful mom. And universally, I would say, when we go to these developing countries to do cleft lip and palate repairs, they're very grateful, and we get a good feeling from it. It's one of my favorite professional activities I do all year. I love to do those operations. We love to help the babies and children. We love to help the families that can't get the help otherwise. They're very grateful to Rotary, very grateful to our American team. And for us, there's very little paperwork. There's very little in the way of electronic medical records. There's no insurance. There's no money involved. Nobody gets paid. Almost always they say thank you, and it reminds us of why we all went to medical school. We get to really help the babies and children and practice our craft, and very little administration, very little paperwork. And so it's really a joy for us to go to these countries and work with the doctors and nurses there and be treated with such hospitality. Again, that was in Guatemala City. One of the other trips I made this year, a humanitarian mission, was to Myanmar. And Myanmar is a very wonderful country, very peaceful people. They were very hospitable. unbelievably grateful to us, wonderful doctors and nurses working with us. Uh, I was surprised at the number of babies and children that we saw in this part of the country, in Myanmar, at the new capital. I think there were over 100 children and babies that came to our clinic on the first day with an unrepaired cleft lip and palate. Really, there's a great need. And as I said, very warm people, very hospitable, very grateful to have us there. And they were delighted to be working with us. And we got to do some teaching. We got to do some information sharing. So here's a baby getting ready to go to the operating room in Myanmar. As you can see, that cleft on the right doesn't quite go up into the nose. So I would classify that as an incomplete cleft of the lip on the right. And so the repair overall is essentially the same. What we want to do is advance that lateral segment and rotate the segment with the philtral column. So that's an advancement rotation repair. Some people call this the Millard repair, named after Ralph Millard. So there we see the repair on the table. We did some work on the nose. Now again, I'm not aiming to have that scar or incision midline. I'm aiming to have that symmetric with the left philtral column because we want to restore the Cupid's bow. We want to restore the symmetry of the philtral columns, and we want there to be some balance and harmony and symmetry in the lip. Now, this is not only a skin operation. We reunite and reconstruct the muscle because it's important as the baby matures that the lip move well as just have an acceptable, pretty appearance. We want the baby to grow up to have good speech and to be able to suckle and eat well, and of course to grow up and be a good kisser. We want children all over the world to have that joy of being able to kiss properly and romantically, even though they were born with a cleft lip. Now here's another baby from Myanmar. I would call this an incomplete cleft on the right. Again, the cleft does not quite extend all the way up into the nose. So what we need to do is advance that lateral segment, rotate the segment with the philtrum, and we also do some nasal work. And again, in this country, we have the rule of tens, where the baby has to have a hemoglobin of 10, weigh about 10 pounds, and be about 10 weeks old. That's about the safe, proper time. I would say the most accepted standard of care, proper time to do the cleft lip repair is to follow the rule of tens at about age 10 weeks. I was about to say that Ralph Millard, a famous plastic surgeon who was in Miami, was working in Korea as part of in a MASH unit in the Korean War. And one of the Korean mothers brought their baby to him when it got out into town that there was a plastic surgeon helping to reconstruct and repair the injured American GIs. One of the Korean babies with their mother showed up at the clinic, and he had in his tent a photograph of the cleft lip of the baby, and he hung that in his tent and he stared at it and he studied it, and then it came to him that all the parts were there, but they were just in the wrong position. The philtrum was mal-rotated. It needed to be rotated back. The lateral segment was there, but it was wide. There was a cleft. And so he came up with this more modern repair, the advancement rotation repair, sometimes called the Millard repair, to advance and rotate segments to repair the cleft and bring the muscle together and work on the floor of the nose and bring some symmetry and harmony to the nose, etc. So that's a more modern cleft lip repair that we do now. For a cleft palate, of course, that's a totally different operation, but we want to close that space in the roof of the mouth, whether it's the hard palate or the soft palate. And here we see the baby on the table right after the repair. We see the philtral column. We see that nice philtrum. The baby looks like he or she's gonna grow up with a very full pout. Cupid's bow is restored. You can see I did some work on the nose as well. And so that's right on the table, cleft lip repair of that right unilateral cleft lip. As I said, the cleft lip can occur on one side or both sides. Here's another baby Another child with an incomplete cleft, as you can see there. The nose isn't too bad. The split or cleft does not extend all the way up into the floor of the nose. Now, I can't tell from this picture if the alveolar ridge is involved. I suspect, it looks to me like there is a slight cleft in that hard palate or alveolus. Again, the alveolar ridge is where the teeth rest. The hard palate is the hard roof of the mouth. The soft palate is that fleshy part back towards the throat that serves as kind of a flutter valve for speech. And also these kids are unable to make a vacuum, and so they get ear infections. They can't drain the eustachian tube as well. They have dental problems. They have a change in the flora of the nasal pharyngeal environment, and so they have some probable increase in chance of infection, etc. And there's a baby. I think this is just switched around. I think the negative got switched. There's the baby with the repaired cleft lip. You see I balanced out the nose as well. We see the philtral column on the side, not in the middle. Cupid's bow is restored. And so there's the baby on the table right after repair. And these kids in Myanmar lined up, as I said, over 100. And again, there's a preoperative picture. There's the baby in the holding area with the very attentive mother. And again, these parents, these families are very grateful for the Rotary team, for the American team. We work with their doctors and nurses. And there's the mom with the baby on about day 3, post-op day 3, repaired cleft lip. They're very grateful. So what we do with these babies, we keep them around in the hospital and tend to their wounds, tend to the incision, tend to the sutures. We keep the cleft lips and palates overnight. Sometimes the cleft palate kids stay around an extra night. They get antibiotics if they need to. And there's the baby standing up, of course, on the mother's knee with a repaired cleft lip, and we did some work on the nose as well. Very grateful, very hospitable people. And there's the mother with the baby that I just showed, and I think the mother standing next to her has a baby with an unrepaired cleft palate. And so, as I said, a cleft can come involving the cleft lip or the cleft palate or together. Very grateful people, very peaceful people. It was very fascinating to us to see every once in a while adults will come into clinics. I've done surgery on unrepaired cleft lips on people who were over 50. And it's really fascinating to us. I recall one man in Bolivia. We did a cleft lip repair on him. He was about 55 years old. He went home and he came back to our clinic and told us that he went home and kissed his wife for the first time. Really quite remarkable. So there's that gentleman in Myanmar with a repaired. He's about 45, as I recall. As you can see, once again, we try to restore the balance and symmetry to the nose, and that incision, that scar, lays right in the philtral column on the right, and we've restored the Cupid's bow, etc. Very rewarding to work with a person with an unrepaired cleft lip or palate that's gotten to be this age, 45 or 50 or 55, and never had an operation. It's very rewarding for us to be thanked by these people after doing the surgery, in addition to repairing the babies. Now, again, here's a cleft lip on the left side that extends all the way up into the floor of the nose. So that's a complete cleft on the left of the unilateral cleft lip. As I recall, this baby also had a cleft palate extending posteriorly, of course. Now the question becomes, do we ever repair the cleft lip and palate at the same time? We do that sometimes, especially in these developing countries. We're trying to get everyone done, all the babies that we can and all the children that we can. And there's the baby with a repaired cleft on that side. That little white gauze on the side of the nose, I use that sometimes as a bolster to help me put the help me keep the cartilage where it belongs. I move the cartilage of the nose around and transpose it and release it and transpose it back to where I like it to be. And sometimes I use a little bolster inside the nostril or even on the outside that stays there for about 5 days. So that's the function of that. Very grateful father. And you can tell from the little boy making eye contact. What's fascinating to me is that these children have totally normal intelligence. Just because they have a cleft doesn't mean that they have any less intelligence. Some of the reputation that these children have gotten over the years who have cleft palates, especially, sometimes a cleft lip, sometimes they get a reputation for not being normal intelligence. It's really because they're afraid to speak up. They don't speak well. Sometimes they get bullied. Sometimes they're ridiculed because they can't make the same sounds as their classmate. And so we think it's really important to give the baby an ability to speak well. So we try to do the cleft lip at about age 3 months. The cleft palate is typically done in this country, anywhere from 9 months to 13 months. We want to bring those muscles together and bring the soft palate together just before the baby starts to speak. Here's a couple other grateful parents, and I should say that must be the mother, and I think that's the sister and the aunt with a young man. I think that's a cleft palate repair. He's borrowing my drumsticks. Of course, he was fascinated with that. And so they're very grateful people. And of course, many of the adults and some of the children have a natural treatment for their skin to improve their collection. It's a natural plant extract that comes from a tree and a plant. I think that's indigenous to the Southeast Asia, and it works as a type of exfoliant. It works as a skin care, and they'll oftentimes apply it to their own cheeks or the baby. Even the baby's skin helps to keep their skin looking fresh, helps them to keep their skin looking youthful and smooth. Very happy. And as I said, it's mainly a Buddhist country, very peaceful people. They brought us to a Buddhist temple one day, and we all felt this sort of aura and feeling of peace, really beautiful, very hospitable, very warm people. And the picture of the roof there, this is the new capital in Myanmar. Of course, the country used to be known as Burma. Now it's Myanmar. You've seen it in the news lately because there's been a big emigration of the Rohingya out of the country to nearby Bangladesh. Very peaceful, very warm, loving people, very hospitable. They treated us so well, and the nurses and doctors worked with us, and we were delighted. Again, that was 2 of the 3 trips I went on this year. In 2018, I went to Cuba after the hurricanes and worked with the Cuban doctors and nurses. More of an information exchange trip. We worked together. I came home and then went to Myanmar and came home, and then I went to Guatemala. It's a lot of missions to do in 1 year, but it's very rewarding, and I'm very grateful for that opportunity to Rotoplast, that's the Rotary Club, and Alliance for Smiles, or Plasticos. If you would like any more information on these humanitarian missions to take care of children with unrepaired cleft lips and palates, you can go to my website, drmorwood.com, and check it out, or call my office, 831-646-8661. Once again, I'm Dr. David Morwood. I am a board-certified plastic surgeon right here in beautiful Monterey, California. We're going to take a very brief pause for a very good cause. I hope you'll stay with us. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. One of the common goals I share with my patients is that they look natural after their facial rejuvenation.
Dr. Morwood made me feel really comfortable. His staff is phenomenal. Going into his office is always a great experience.
Call or click today to learn how our combined approach of art and science can enhance your natural beauty. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. A smooth, firm neckline is a universal sign of beauty in both women and men.
Dr. Morwood not only helped me regain my confidence, he helped me achieve the best version of me.
Call or click today to learn how the natural neck lift can rejuvenate your beautiful neck and jawline. Welcome back to the Doctor Is In television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon here on the beautiful central coast of California, right here in Monterey, Pebble Beach, and Carmel, and Pacific Grove. Thanks very much for being here for this segment. What I'd like to discuss is some of the mechanics of the natural neck lift or facial rejuvenation, the recovery period. I think that's very important, and how adjunctive procedures such as chemical peels, TCA peels, croton oil peel, the croton oil phenol peel, or facelifting, in addition to the natural neck lift, how that can change the recovery period, what the recovery period is like, and talk a little bit more about the mechanics of how we choose where to do the operation and issues like that. First of all, I want to review. You've heard me talk about the triangle of beauty or triangle of facial rejuvenation. Every triangle has three parts. There's the skin, there's volume changes, and then there's soft tissue position and amount. That triangle rests upon a foundation. And of course, the foundation is the craniofacial skeleton, of course. Now, you know about the skin. That's the texture of the skin, the superficial skin. And we treat things like age spots, fine lines, wrinkles with treatments such as laser or croton oil peels or TCA peels. That is not a replacement for a facelift, but what I feel strongly about is that for effective, natural appearing or natural resulting, long-lasting, high-quality plastic surgery, we need to address all those components separately. Now, you don't necessarily have to, you're not going to get a guarantee that you have to have a peel if you have a natural neck lift, but what we need to do is design a custom approach, a custom designed approach for you based on what you need. And the principles in my practice of designing a custom designed approach, a custom approach, is to follow the triangle of beauty or triangle of facial rejuvenation. So there's the skin. So we're talking about the texture, fine lines, pigment changes, hyperpigmentation, liver spots, aging spots, etc. Those are best treated with things like chemical peels, sometimes laser, etc. Then there's volume changes. You've heard me talk about, as we mature, we tend to lose fat in the face and in our hands, and we put fat on in the trunk. That's an unfunny practical joke. But there certainly are volume changes. Now, how do we revolumize? How do we reverse some of those changes? The first easy way, when you don't need a lot of revolumization, is with fillers. Things like Juvederm, Restylane, Belotero, Voluma, etc. Those are volumizers that can help restore volume. We can bring the chin forward a little bit. We can augment the cheekbones. We can accent the mandibular angles. We can fill in the hollow temples, etc. So those are fillers. What's the other broad category of revolumization? That is with fat grafting. Fat grafting is when we do conservative liposuction from somewhere where the fat cells typically persist, like the trunk, love handles, the lateral thighs. Some people call those the saddlebags. I'm not allowed to use that term in my office. My wonderful staff doesn't allow that. However, they do allow me to call men's prominences the love handles. I'm not sure why we have that gender difference. But we take fat from the trunk, we spin the fat down, and then keeping it sterile, we sometimes cleanse or decant the fat, and we can re-inject it to, say, restore cheekbones, fill in what we call submalar hollowing, accent the mandibular angles, bring the chin forward, help to restore the foundation for the nasolabial folds or the piriform sinus areas, fill in the temples. So that's a person's own fat, and we recreate. It's a lot like Johnny Appleseed. We spread out these seeds, but in very specific places. Some of them will take, some of them will not. About 67% of the volume will persist. And it's a person's living cells. If a person ever gains weight, their cheekbones will get bigger, just like if they have not had fat grafting. If they lose weight, things will get smaller. It's your tissue. It's living, breathing, bleeding. It needs blood supply, etc. It's you. It's sort of a natural replacement for that fat that's lost with hormonal changes as someone matures. I've heard women say, I feel like I've become from a plum into a prune, or I've turn from a grape into a raisin. So what we want to do is have a volumetric restoration. We want to lift and fill. We don't want to pull so hard and remove extra skin. We don't want to pull so hard until the wrinkles disappear and then cut off the extra skin and sew up. That may be the older way to do a facelift or the more traditional way to do a facelift. What we want is a projecting face. We want full cheekbones. We want full cheeks. Think of a baby with lots of fat in the face. So we talked about the skin part of the triangle. We talked about the volume part of the triangle. Now, what about the soft tissue position and amount? That's what people typically think of as plastic surgery. We're lifting, we're removing some skin, we're repositioning, we're firming up. And so in my practice, again, we need to look at the individual components that rest upon the foundation. Sometimes we bring the chin forward, sometimes we adjust the ears or the nose, cheekbones, etc. You don't have to, you're not mandated to sign up for all three parts of the triangle. But I think we should talk about what you need. Have you lost volume? What part of your face and neck are we going to address? The eyes, etc. And I think we've entered an era where it's component restoration. You can just have what you want done. You don't have to have whatever that phrase complete facelift is. You don't have to have a complete facelift. You can if you want. It's not required. You can have only the eyelids done, only the neck done, only the mid-face done if you'd like, etc. So I want to talk a little bit about the logistics and mechanics of these operations. Probably in other of my other teaching segments of mine, other teaching videos, you can learn more about, say, the actual operation of the neck lift. We go step by step. We address the surface of the skin, the amount of the skin, the subcutaneous fat, the platysma muscle, the subplatysmal structures, and we need to go, and the chin and the jaw, etc. We need to go step by step and layer by layer. Now, for facial rejuvenation, it's a similar thing. We need to address the triangle of beauty. We need to address each component, at least talk about them so you understand your options. And probably during your first consultation, we'll do the computer imager, the Vectra. That's a $40,000 piece of technology that my patients really enjoy. It's 6 cameras attached to a computer. It takes just an instant to have your image taken. All 6 images are fed into the computer, and it's sort of like computer-aided design. We can rotate you, you're in 3 dimensions, we can look at you upside down, we can do some sculpting, molding, tailoring, etc. to give you some idea, not a guarantee, but some idea of what's going to go on. So, the mechanics of it. How do we choose where to do an operation? First of all, in my office operatory, we have a very functional, I like it, very functional, usable office operatory. We have an autoclave, we have tons of betadine, sterile instruments, on and on, new sutures, and whatever you need, we have that's sterile and clean, etc. We have a great light. I put on my fiber optic light. We have loop magnification. We have an overhead light. We have overhead exhaust, etc. But in the office, we don't start an IV. So what is it that we do? You can come in and take sedatives. If necessary, if you would like, you can get a whiff of the nitrous oxide oxygen mix. We take your vital signs. You can get an oral sedative, not an IV, but an oral sedative. You can take a Benadryl, Tylenol. Sometimes we give a narcotic, and it's certainly an antibiotic. We let all that soak in or take effect, and then I start to numb. And numbing is done with a needle, so that can sting. And that's when sometimes people will take a whiff of the nitrous oxide. Some people call it laughing gas. It's in a lot of doctors' offices. Now it's used in the emergency room. Even children can get it. It's used in labor and delivery for women in labor, takes away the edge of the pain. It's a dissociative medicine. You might feel the sting of the needle, but it really doesn't bother you. I find my patients really like it. And you're being monitored. We check, as I said, your pulse oximeter is constantly being monitored. We check your blood pressure, we check your pulse, etc. So we numb up the skin after you're sedated, but with the oral agents, the pills. Then when that soaks in, we numb up the deeper tissues. I use a very dilute local called Hunstead's formula, and that doesn't feel so bad. But then we let all that soak in. So you're very relaxed, you're numb, but you're awake and you're being monitored. We don't start an IV and we don't intubate people in the office. That's good for people who don't have uncontrolled medical problems, if you don't have diabetes, if you don't have high blood pressure, if you don't have any cardiac history, no lung problems, if you're in good shape and you're young, and if you're of the kind of personality that you can relax. If you simply can't relax around needles and medical discussion and instruments, well, then you probably need to go to the next step. Now, what's the next step? The next step, I'm going to group together the outpatient surgery center at the hospital or the surgery center. We're lucky that there's a surgery center in my building, and there's a facility on nearby, just 2 blocks away on Cass Street. What happens there? An IV is started, and those same medicines, a sedative, antibiotic, narcotic, is given right in the vein, and you can tell the anesthesiologist how deep you want to go. You can take a nap, you can get a deep general, a light general, you can get sedated, you can go twilight, you can get sort of daydreamy, and then I numb you up. And we want you to be comfortable. We don't want anything to bother you. I numb you up the skin, numb up the deeper tissues. You can take a nap if you want, as I said. You can just request whatever you want and speak to the anesthesiologist. Of course, there's another nurse and an assistant, a scrub tech, the anesthesiologist in the facility. That has some increased costs. However, for the person who needs that or wants that, it's certainly well worth it. Certainly well worth the cost. And that's done either at outpatient surgery center at the hospital or at the accredited, licensed, and certified, licensed, accredited, and certified surgery center, Monterey Peninsula Surgery Center, here in Monterey. And there are a number of campuses. Now, you can have your operation. We watch you in the recovery room. If we do this in the office, we watch you for a while, and you can walk out by yourself. You don't have to stay overnight at the surgery center or even the hospital. Now, in some instances, you have an option to stay overnight if we plan this out ahead of time, or if there's some necessity to keep you overnight at the hospital or the surgery center. But you don't need to, say, for the natural neck lift or facial rejuvenation. If it's done in the office or at the outpatient surgery center, you leave, and we see you in the office the very next day. Now, what about the recovery period? I want to talk about the recovery period for the natural neck lift, depending on what you have done, for most types of facial rejuvenation. And then I want to talk about the adjunctive procedures for fat grafting and peels, whether it's a TCA peel or croton oil phenol peel. Now, just the natural neck lift or facial rejuvenation, the facial, let's say, face lifting or elevation alone. As I said, rest and elevate and take it easy at home for 3 days and 3 nights. Doesn't mean lay in bed. We don't want you to lay in bed. Short walks to the kitchen and to the bathroom and maybe check the mail, that's okay. But this is your time to be home and listen to your favorite Mozart records or Beatles records, or watch Turner Classic Movies, catch up on email, or write letters if anybody writes letters anymore. Just hang out and be mellow. Rest and take it easy at home for 3 days and 3 nights. We want to see you in the office the very next day. For most of these procedures, you can shower that night, 24 hours after the operation, or you can wait till the next morning if you want. A light dressing for a day and a half is all you need. Then on day 4, a little more activity, but don't get your blood pressure up high. Walking the rec trail is fine, easy walking, easy elliptical strider, easy stationary bike, easy on the treadmill walking, but no pumping iron, no hard jogging, no sprinting, no lifting really heavy amounts. You just go easy starting on day 4, a little more activity. Fresh air is good. We have a lot of people who get a baseball cap and a pair of sunglasses and a scarf, and they walk the rec trail from Monterey and Carmel to Pacific Grove, etc. Feels good to walk. Showering is good. Then on day 11, slowly get back to your life. by that day, or 10 or 12, if we use some staples behind the ears, they're coming out. The sutures are starting to melt. And we have plenty of people on that day 4, a little more activity, who will go to their desk, work on the phone and do paperwork, etc. On day 11, a lot of people are interacting with the public. The swelling and bruising is probably less than you anticipate. So on day 11, it's slowly progressed to your life. Now, what about if we add fat grafting? And what about if we add a peel, such as a TCA peel or the phenylcrotonyl peel? You're going to be swollen and bruised for about 3 weeks. You're going to be overcorrected if we do fat grafting. I don't think you're going to want to have a portrait picture taken for 3 weeks. So you're overcorrected. As I said, about 67% of the volume persists, and so we want to overcorrect. You're overcorrected for about 3 to 6 weeks. Usually the bruising is not all that bad. There is some swelling, but typically you're going to look sort of chipmunk-cheeked, and you're not going to want to go to a dinner party for about 3 weeks. Now, what about the peel? TCA peel or crotonyl peel? Overall, not that much happens for 5 or 6 days. And then for 5 or 6 days, you exfoliate, you peel, you shed. Then you have smoother, pinker, softer skin. It takes about 6 weeks for the pink skin to fade away. You can put makeup on it, but most people aren't that comfortable going to a dinner party without makeup or having a portrait photograph taken for those few weeks. You're going to want to wear makeup after the exfoliation period finishes, which is at about day 12, 10 or 12 after the peel is done. 5 or 6 days, not much seems to happen. 5 or 6 days of rapidly exfoliating. Now the TCA peel and the crotonyl phenol peel, to talk about the differences will take us about half an hour or 20 minutes. We can do a segment on those. Oftentimes with the crotonyl phenol peel, I'll do a bismuth mask we tape overnight, then the next day take the tape off, apply a bismuth mask. It's sort of like a green mask that you wear. That'll come off after about 10 days. For the TCA peel, it's a lot of antibiotic lotion, emollients, and lubricants. But the point I'm trying to make is that if we do fat grafting and or a peel at the same time we do the natural neck lift or the lifting for facial rejuvenation, your recovery period will be extended. You're not going to want to go to a dinner party at about day 10 or 11. If we do the lifting alone, it's a reasonably rapid recovery. Now, doing the fat grafting and TCA peel is a longer recovery, but it's more change. You're going to get more rejuvenation if you need it. It's more powerful if you need it. So one of the important take-home lessons is a custom designed approach is really the best for you. If you only need a peel, if you only need fillers, if you only need Botox, if you only need a natural neck lift, just have what you want and need, nothing more, nothing less. But the more invasive the procedure is, typically the longer the recovery period and the more invasive the procedure is, it's probably more powerful and the effect is more profound. So my advice is custom designed approach. Take the time, be educated, sit with me, go through the facial analysis. We go through layer by layer, do the vector computer analysis. We can talk about potential result, possibly do some sculpting for you. And keep in mind, a natural result usually comes more consistently with following the triangle, the triangle of facial beauty, triangle of facial rejuvenation. The triangle lays upon on top of the foundation, and also keep in mind the more invasive the procedure, likely to be more recovery period and a more profound effect. So I hope that's helpful for you. If you want any more information about the natural neck lift, about facial rejuvenation, about the triangle of beauty, about peels, about revolumizing with fat grafting, I hope you'll call my office, 831-646-8661. Or go to my website, drmorwood.com, drmorwood. Thank you, Michael Martins, in the control booth. I'm Dr. David Morwood. This is the Doctor is In television program. Thank you very much for being here.